Good morning, everyone. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN project. Thank you all for joining us today and our friends at Generations Family Health Center in Connecticut for requesting today's session. It's called Advanced Care Planning and End-of-Life Care with Dr. Peter Candell. Dr. Candell worked as a family physician for almost 30 years, where he served as medical director for a large medical group in the San Francisco Bay Area. He is an assistant clinical professor at the UCSF School of Medicine. In addition, he is part of an educational initiative with a group of physicians at the Alameda Contra Costa County Medical Society, which focuses on advanced care planning. We are so happy to have you here today. And Dr. Candell, I'm going to turn it over to you.
Thanks, Jill, and hi, everybody. Welcome. Thank you for joining us. By way of introduction, I just want to be clear.
Great. Peter, are you able?
Yeah, problem? Can you hear me? Uh-oh. Frozen? Hello? Uh-oh. Hello?
They can all hear you. I think her camera just went out, so you can proceed.
Oh, okay. It's not me.
No, I think it was Dr. Jill.
Okay. Well, again, welcome, everybody. Thanks for joining me for this. I want to make it clear from the beginning that the focus of this talk is not about medical legal aspects of advanced care planning and end-of-life care. Jill, are you back with us?
I'm back. Thank you. Sorry about that. Go ahead.
I thought it was me. Anyway, so I was just saying that the focus of this talk is not about the medical legal aspects of advanced care planning and end-of-life care. Rather, it's about the communication process between providers and patients about these challenging issues. And as many of you probably already know, there are many challenges associated with having this kind of conversation with patients. But where there are challenges, there are opportunities. Hence, I want to talk about both of these as we proceed. As Jill mentioned, there will be a Q&A at the end, and we can review questions and respond to your questions and comments via the chat as well. So just want to be clear about no conflicts of interest, which is a standard requirement. Accreditation, Jill has already mentioned. I'd like to spend a moment just reviewing some of the objectives that I hope we can accomplish during this talk. One is articulate reasons why discussing advanced care planning and end-of-life care decisions are challenging and difficult for both providers and patients. Integrate essential first steps in the conversation with your patients. Raise important questions for the patient and their families to consider to help them make the right decisions. Learn how to find the best opportunities to raise the issues during interactions with patients. Become aware of cultural differences in your approach to these issues, which is a very important area that could take a whole talk by itself, but we'll at least discuss that a bit. And finally, understand the role and importance of palliative care in seriously ill patients. Okay. And with that, meet Mr. Jones. This is a hypothetical patient. The data is made up, but I think he represents a very real scenario that many of you may already be familiar with in some ways. So Mr. Jones is a 77-year-old male who just had a lung biopsy, which confirmed an adeno-CA, and the CT of the abdomen prior to his discharge revealed multiple hypodense nodules consistent with liver metastases. So after discharge, Mr. Jones sees his primary care doctor, Dr. Smith, for an appointment, and Dr. Smith reviews Mr. Jones's other medical problems, which include what you see below. The message here is obviously he has multiple comorbidities that are significant and have a significant part to play in how you approach Mr. Jones's advanced care directive of end-of-life issues. As noted, he takes his medications regularly, and he says he feels not too bad today. He's not coughing too much, no dyspnea at rest, on low flow O2. His vital signs are stable, mental status grossly intact, although he's forgetful at times. His family members are anxious to hear about final results of the test and to plan next steps. So Dr. Smith is thinking to himself, aside from coordinating care with the oncologist, it's appropriate to talk to Mr. Jones about an advantage which Mr. Jones has never given much thought to, and end-of-life wishes. But does Mr. Jones want to go there? How do I find out? And how can I help Mr. Jones and his family decide what's best for him? So Dr. Smith is very concerned about bringing these issues up, but doesn't have a whole lot of experience knowing how to do so. So before we proceed any further, I'd like to review some aspects of the problem and challenges. And this is data that's back from 2012 in a survey of patients. But I think the numbers are still close to being true. So 90% of people in this survey said that talking with their loved ones about end-of-life care is important, but only 27% have done so. 80% of people say that if they're seriously ill, they want to talk to their doctors about wishes for medical treatment toward the end of life, but only 7% report having had the conversation with their doctor. 82% of people say it's important to put their wishes in writing, but only 23% have done it. And as I said, this is a survey. This was done here in California by the California Healthcare Foundation back in 2012. And although gaps have probably narrowed over the last several years, I'm quite sure that significant gaps in each of these areas persist. So that's part of the problem, the challenges. Plus, turns out, and this is another survey, this time of physicians, most doctors are unsure about how to discuss end-of-life care. From this survey of 736 providers, both primary care and specialists. And among the findings from this survey, 3/4 of those surveyed physicians believe that it's a responsibility to initiate end-of-life conversations. Fewer than 1/3 reported any formal training on end-of-life discussions with patients and their families. And more than half said they had not discussed end-of-life care with their own physicians. So gaps both on the patient side and the provider side. So those are some of the challenges that we can review. And these are some additional challenges that may underlie some of the gaps we just talked about. One is that patients often distrust recommendations from the medical community to limit care, regardless of prognosis. And we'll come back to that. Cultural and language barriers can often be important, as we'll see later on. Anxiety and or denial about mortality can be an important factor here, and that, of course, goes for physicians and providers as well as patients. And last, but often not least, in this list is time. This is my own list, by the way, but comes from my experience in practice over the years. Time is obviously an important issue that needs to be addressed as well, meaning time constraints in a busy practice. This is a survey put out by the Journal of Palliative Medicine in October of 2015, and it was entitled Patient-Reported Barriers to High-End Quality End-of-Life Care. And these are the 6 barriers that this diverse group of patients described. 1, doctor behaviors. Doctors lack empathy. 2, a communication chasm between doctors and patients. Aside from the lack of empathy, difficulty understanding medical terms. That is the use of jargon and describing difficult issues to patients in terms of their diagnoses and prognoses, which made it difficult for patients to understand. Finances, health insurance barriers, lack of access to affordable care. Family beliefs and behaviors. Avoiding conflicts when end-of-life issues are discussed. Lack of help to complete medical directives, perceived as a healthcare system barrier. And finally, cultural and religious barriers, meaning a religious belief that it's not appropriate or correct to discuss end-of-life issues. So those are the barriers that were listed, the main barriers in this survey of patients. And interestingly, number 1 and number 2 are listed as number 1 and number 2 because those are the most common ones. And those are the ones that I always like to focus on because those, I think, are great opportunities to improve. And by the way, getting back to the time issue, I've got 20 more patients to see in clinic today, so how am I possibly going to do this? So that is an ongoing concern, needless to say, with no simple solution, but opportunities that we can address. So, starting the conversation. Given the above issues, how would you start the conversation with Mr. Jones? And I know I said there'll be time for questions and comments at the end, but I am interested in, if possible, throwing this open a little bit now and get some input from you folks to see in your experience what you've found to be successful.
So, Peter, as you maybe continue to talk, I'll let you know if there's any comments
Okay,
that come in through the chat, so people can feel free if they want to in the chat.
we'll close the chat window for now and continue, and we can come back to that. Okay, so this is something that I put together some time ago and came up with some various objectives regarding opportunities that I'd like to share with you.
And
And
Peter, there's a couple comments coming in. Um, and one of them says, I write to schedule them at the end of the day for more time, like having those kind of conversations, being very direct, saying it is time for the talk. Um, and it's important to not feel rushed. Just so thank you very much for those comments, everyone.
yeah, for sure. The idea of scheduling things at the end of the day to allow you to have that time is a good idea. Uh, and how to approach the topic and how direct you are is something that is very important. And I'd like to spend a little more time on that one. So we'll talk about that. So again, this is my series of suggestions. Some of it's borrowed from something called motivational interviewing, which some of you may be familiar with. So for me, initial objectives involve establishing or reestablishing rapport with the patient and setting the agenda. So what does that mean? So for example, you could say, I'm glad to hear you're feeling okay today, Mr. Jones. You've been going through a lot lately. And why that's important, it establishes a sense of empathy that and trust, hopefully, that the patient can hear and allow the patient to feel comfortable or start to feel a little comfortable about discussing these difficult issues. So establishing rapport with a sentence like, I'm glad you're feeling okay. You've been going through a lot. We could also add, we have a lot to talk about, and after we review test results, we can start talking about next step and future plans. So letting the patient know that there's a lot to talk about. We'll review results. This may not happen all in one meeting or appointment. And also you and your family may want to talk about this at home. So it'd be important to set up another appointment to continue the conversation. So that's letting the patient know that this is not a simple one appointment topic. Somebody already suggested that. And also making clear that continuity of care is important. So you as the primary care provider are not going to just disappear once the patient is referred to the oncologist, say. You're going to hopefully continue to be connected to the patient and see them and follow up to follow things along. Providing more context for the conversation is also important. And what I mean by this is, for example, saying, I'm concerned about your overall health. Have you thought about what kind of treatments you'd want or not want if you get really sick again, or if you just get really sick? And again, empathy, sharing your concern about the patient's health is important. I also like to say something about how hard it is to talk about this, that it's difficult to have this conversation. However, it's very important for you and your family to start thinking about what matters the most to you. So acknowledging the difficulty is another way of really confirming the trust and the rapport. I want to make sure I understand what your concerns are and what your wishes are. So this, again, from motivational interviewing, is a way of getting toward being able to reflect what you hear the patient is saying and that you get it. So you could say after you ask the initial questions and they start to talk about it, you can say, let me see if I've got this right. I think what I hear you saying is that if you become critically ill, you don't want to be on a ventilator for a long period of time. Is that right? Am I hearing you correctly? So verifying that, reflecting what the patient is saying, I think is very important. And handouts. Handouts are going to help you and your family get started about thinking more about this. And we could talk more about it the next appointment. So at the end, I have a few references which include access to very good handouts, brochures for patients regarding advanced care planning and end-of-life care. And if you don't already have something like that for your patients at your clinic, I highly encourage you to research that and get some information that you can readily hand out to patients. There's more than one way to do this, and I wanted to spend just a couple of minutes on a separate approach that's used from the Dana-Farber Cancer Institute. It's a script, meaning that they use this for their cancer patients and record it in the medical record based on the answers to 7 questions. So the first question is understanding. What is your understanding now of where you are with your illness? Information preferences. How much information about what is likely to be ahead with your illness would you like from me? There are different ways to phrase that, but the concept is important because not all patients, as you probably know, can absorb the information, especially if it's not favorable, can absorb that all at once. So it may be important to just start slowly with providing relevant information. Depends on the patient, and some patients, of course, want to hear exactly what's going on and what the plans are going ahead, and they want to hear it quickly. And that's fine. You just have to be attuned to what you think the patient is able to absorb at any particular time. Number 3 is goals. If your health situation worsens, what are your most important goals? And kind of the flip side of that is fears and worries. What are your biggest fears and worries about the future with your health? Number 5 is function. What abilities are so critical to your life that you can't imagine living without them? Number 6, trade-offs. If you become sicker, how much are you willing to go through for the possibility of gaining more time? And I think this is a very important issue that's difficult to talk about in a lot of situations. A lot of times patients focus on the amount of time they have without also considering the quality of that time, the quality of their lives during that time. And I have to say, in my own experience, that among oncologists that I refer patients to, some of them fall into that framework as well. That is, they talk with patients about this treatment may be giving you 6 months more time, but they don't really focus on the quality of life in discussing that with patients. So I think as a primary care provider, it's important to bring up the trade-offs issue. And finally, how much does your family know about your priorities and wishes, and how much do you want your family to know? Some people want to keep the information to themselves, and it's important to feel that out as well. So again, this is from the Dana-Farber Cancer Institute. It's part of a script that they include in their medical records for patients with advanced cancer, and may be very helpful for some of you. Okay, so now I'm going to switch to some additional suggestions, and we can come back to these at the end. Number 1, become familiar with resources for your patients. And what I mean by resources is resources within your clinic, if you have some, that is ancillary providers to meet with patients or provide handouts, but also community resources, social workers, psychotherapists, clergy, all can be very important. And if you have some resources at your disposal that you can refer patients to or ask them if they'd be interested in them, I think that can be very helpful. Some patients already have contact with their clergy, and suggesting that they speak to their clergy uh, uh, about their concerns and fears can be very, very helpful. This is something that's used by the Dana Cancer Institute and other places, which is to consider specific subsets of patients to engage in the conversation. So if you have a patient panel and there are a select group that fall into any of these categories, it might be appropriate for you to flag those charts in some way so that you can remember to raise the topic of advanced care planning and end-of-life care challenges when you see them. This is very important. Trying to have these conversations at the time of a crisis or an acute exacerbation of a serious illness is not a great time to do this. For example, in the ER ICU, the stress the patient is experiencing, the family is experiencing, is enormous often, and it's a very difficult time for patients and their families to have meaningful conversations. Sometimes you have to do it in that situation because it's that serious, and there aren't alternatives, but it's much, much better to have the conversations in a more relaxed outpatient environment. Involve support staff in providing materials. I've kind of addressed that. And of course, schedule follow-up appointments to continue the conversation. We've already suggested that. The American College of Physicians, oh yes, of course, document the decisions that are made. That goes without saying. Any decisions need documentation. The American College of Physicians put out something called Tips for Physicians from part of their website called Improving Your End-of-Life Care Practice. And I thought this would be worth sharing too. Similar issues, but worth reviewing as well. So look for opportunities to raise issues such as times when the patient expresses concerns or fears or notes the illness or death of a relative. So if you have a patient in your office or clinic who happens to mention a close relative who's dying, that can be used as an opportunity for you to say, well, let's come back to you a bit about this. And have you thought about what you would like or considered an advance directive yourself in the event that you were to become very sick? We've already mentioned don't need to discuss all issues in one visit, and scheduling an additional visit specifically for the conversation can be very important rather than just a routine follow-up visit. That emphasizes again the continuity of care and the importance that you place on this conversation. We've already talked about getting community folks involved and knowing your resources. If the patient agrees to include the family and friends and encourage agenda setting for the patient and their family, and that goes back to the handouts that hopefully you'll be able to give them. And they also recommend using an episode in the ICU or ER as a rehearsal if appropriate. That is, if the patient comes to you after being in the ER with a serious illness or the ICU, you can use that as an opportunity to say, well, what do you think should happen if this happens again regarding surrogate decision-making, hospitalization, CPR, pain relief, etc. So having that as a reference point can be very helpful. I want to shift gears a little bit and come back to the ethical and cultural caveats and being aware of respecting differences, because this is, as I said at the beginning, we could have a whole hour talking about this, but there are a few particular issues that I'd like to focus on, and I would imagine that in many of your patient populations, you have fairly diverse populations with different cultural and ethnic backgrounds, and there are different perspectives that come along with those that are important to address. So number one is a cultural view on decision making, and we've kind of alluded to this a little bit. Is it an individual process or a family process? In some families, the individual wants to make all the decision, doesn't want the family involved. At the other extreme, in some cultures, the family may take primary responsibility and the patient, him or herself, may defer to a family member or a group of family members, say whatever they say. So it's important to feel that out and decide who you're having a conversation with and who's making the decision. Communicating bad news is especially difficult in any context, but it's especially challenging when you were talking about ethnic or cultural differences. So, for example, working with interpreters. I don't know how many of you work with interpreters, but just to share a brief anecdote about how this can play out. I, once in my practice, I had an elderly Asian gentleman who spoke very little English in for an appointment with an interpreter. I believe it was a Cantonese speaking patient And the patient had a story not too different from our patient at the beginning, Mr. Jones, with COPD, heart failure, and cancer, although it hadn't metastasized. And at the prior appointment, the patient had talked about having a little bit of shortness of breath. And so I asked the patient, or asked the interpreter to ask the patient, have you had any shortness of breath or chest pain in the last couple of weeks since I saw you last? The interpreter dutifully repeated the question to the patient, and the patient responded over about 45 seconds or a minute, including hand gestures, holding his hand to his chest, describing things over a period of time, as I mentioned. And then at the end, the interpreter turned back to me and said, he says, no. So that left me a little concerned about how the interpreter responded to the patient's answer by deciding that the interpreter could summarize it in one word, no. And so I urge you, if you do use interpreters, to make sure you let them know that you need to have, as best as he or she can, a word-for-word translation of what the patient is saying, not a summary. Choosing keywords carefully. This is very important as we address cultural differences. In some cultures, using the words death or dying are absolutely taboo. You just don't want to do that or go there, and you can easily destroy a sense of trust between you and a patient and their family if you choose words that are inappropriate for them. So being sensitive to that is important. And for example, ways to work with that are instead of using words like death and dying, say, if things don't go the way we hope them to, or if things turn out not to be going well or getting worse over the next few months, what do you think you or your family would like to do, or how would you like to proceed? So choosing words carefully and avoiding taboo words very important. And again, deciding who to include in the conversation is very important and must be respected in various cultures. Specifically regarding advanced directives and end-of-life care, there are implications of limiting care, and I mentioned that earlier. Implications of limiting care, care got eliminated here, sorry. But implications of limiting care are very important. So it's important to structure your conversation. So instead of limiting care or withholding care, you want to focus on quality of life. We touched on that earlier, but talking about how your quality of life matters as we go forward. And that limiting care is not withholding care, but choosing care that really will make things best for you in the time you have left. So refocusing the quality of life, the team approach, and palliative care, which we'll come back to in just a minute, and the role of spirituality and religion, as I talked about earlier, can be very important here. These topics are borrowed from an article back in 2005 from the American Family Physician. This is just a slide to illustrate that starting the conversation, and this again from the Coalition of Compassionate Care in California, starting the conversation can be appropriate in any adult at any time, even when they're healthy. Obviously, you don't want to introduce the topic to everyone when they're young and healthy, but some patients would like to start talking about it when they're young and healthy. So being aware of that and introducing that when appropriate is fine. And it's important, as the slide illustrates, to come back to that periodically as you follow the patient over time to update or change it. And once a patient is diagnosed with a serious chronic or progressive illness, you may get to a PULSE form so that treatment wishes are honored. And regarding a PULSE, I'd like to spend a minute on that and distinguish it between an advance directive. And I assume that many of you are familiar with the PULSE, the physician orders for life-sustaining treatment, versus an advance directive. And just very briefly, just to highlight the differences, the PULSE is a medical order that's to be completed by a health professional. The advance directive is a legal document completed by the individual. The PULSE is for people who have serious medical conditions, to focus on end-of-life decisions. Advanced care directive can certainly be initiated at any time for healthy, capable adults. The PULSE is for first responders at the time of action that is needed. For example, if somebody collapses at home, an EMT arrives. If there's a PULSE on the refrigerator, they can use that to decide how to proceed. The PULSE does not designate an individual to make decisions, but gives advanced medical orders, as opposed to an individual is appointed to make decisions in an advanced care directive. This notes that depending on the state, the agent named to make healthcare decisions can complete or change or void a PULSE. But in an advanced care directive, the agent named cannot modify the advanced care directive. So that summarizes that. I think we can go on. Just want to make sure you folks are all familiar with the distinction. Care, but there are important differences. So let's look at that. Palliative care, including emotional and spiritual support, can be appropriate for any patient with serious or life-threatening conditions while undergoing curative treatment. It's not just care at the end of life. Another anecdote, briefly, that I wanted to mention was when I was working as a medical director, I visited an oncology office, and all 4 of the oncologists had signed documents on their walls that they had were certified as palliative care providers. So I asked them, "Oh, that's great. And so how often do you actually provide palliative care?" And they looked at me and looked at each other and basically said, "Oh, our receptionist takes care of that. She gives them handouts." So I wouldn't assume, as I kind of alluded to earlier, that the oncologist is offering palliative care either directly or indirectly, and that it may be important for you as a primary care provider to bring up the topic of palliative care and describe to an appropriate patient when it's going to be helpful. So the Journal of Clinical Oncology in May of 2015 did a study comparing early versus delayed initiative of concurrent palliative care, and found that early palliative care provides anticipatory guidance about symptom management and thoughtful discussions on advanced care planning goals that engage individuals to consider their values and care preferences in a more relaxed environment than the acute care hospital. Quality of end-of-life care provided to patients with serious illnesses. This is from an article in JAMA in 2016. This was a survey of family-reported quality of end-of-life care, and it found that it was significantly better for patients with cancer and those with dementia than for patients with end-stage renal disease cardiopulmonary failure or frailty. And that was largely owing to the higher rates of palliative care consultation and DNR orders and fewer deaths in the ICU among patients with cancer and dementia. So the point is, cancer and dementia patients received palliative care more than patients with other very serious end-stage diseases, and the difference mattered in terms of the end-of-life quality of care for those patients. So the point being, don't restrict quality of care and palliative care issues only to those with cancer and dementia, but think about it, any patient with end-stage disease or life-threatening illnesses. Increasing access to palliative care and goals of care discussions that address code status and preferred setting of death, particularly patients with end organ failure and frailty, may improve the overall quality and end-of-life care for Americans dying of these illnesses. So that pretty much concludes what I had to say. I want to just show you some resources that I had mentioned earlier. These resources I found to be very helpful, both for myself as a provider and for patients. So the Coalition for Compassionate Care in California, even though it's a California-based organization, is available online to anyone and has very helpful advanced care resources, including advanced care directives, including something called 5 Wishes, which maybe some of you are familiar with. Prepare for Your Care, also a very, very helpful site, and helps a patient walk through the process of thinking about the conversations required in advanced care planning. So that's important. Begin the Conversation also provides resources both for patients and providers. And as you can see, this particular site is resources for providers. And there are trainings, workshops for healthcare professionals, including those at the website called Vital Talk. So I'd encourage you to use these resources and take advantage of the benefits they can provide for you and patients. And that's it. So let's open it up to questions, comments.
Great. Dr. Candell, thank you so much for that presentation. I'll have you actually stop your share
Okay.
screen now, and just wanted to encourage any of the listeners to share any barriers that you face as a clinician in talking to your patients about this, as well as any tips or things that have worked well for you. And I'll give you a moment. You can feel free to put comments in the chat or any questions in the Q&A box. And we'll wait to see if anything comes in. And then while we're waiting for any comments, I just wanted to remind everybody that MAVEN Project offers clinical mentoring and leadership coaching opportunities for our partner clinics. So if you are a clinician that would appreciate meeting with an experienced mentor, it can be in primary care where you want to do some clinical case review or discussions. If you want to talk about time management, burnout, career advancement, we can definitely get you set up with somebody that you would meet with one-on-one. Sometimes people meet, let's say, every other week for up to an hour through our video platform. It's a confidential and kind of customizable relationship. And so when you log into our MAVEN community portal and click on mentoring, you can submit an inquiry form, and then we'll match you with one of our great physician volunteer mentors. And then also for those of you that are in leadership positions, if you're a site director, a chief medical officer, if you are, managing a certain program, if you're new to leadership, if you're an experienced leader, we can also set you up with your own personal coaching. And so we just strongly encourage you to take advantage of that access. So it doesn't, oh, let's see here. We have a question. Are there video resources for families on how to discuss end of life with their loved one, such as for children of a parent with cancer? That's a great question.
And if you saw the, the resources that I mentioned in the slide just a moment ago, at least one, maybe two of those provide videos as well as brochures and handouts that are designed for patients to have those conversations. So yes, and they're definitely helpful or have been helpful to me when meeting with patients.
Great. And here's a nice comment in the chat. For delivering bad news to a person from a different culture, I have found it helpful to seek medical cultural competency information on the internet. It is important, however, to remember that the information may not be correct or may not apply to that particular person.
It's a great idea, though. I think checking on cultural competency issues and using them when appropriate can be very helpful. So good suggestion. Thank you.
Great. And in the Q&A, is there anything good to know about nuances specific to the Latino population?
The only thing that I would say in that regard, and I can't speak from a whole lot of experience in my practice regarding Latino patients, but some, the only thing that I would say is that religion and spirituality often play a very, very important role. Latinos are typically Catholic, and religion is an important part of their lives. And that plays into some of the things we talked about when we talked about being aware of cultural differences. So again, using words like death and dying might not be appropriate. But again, cultural competence issues vary even within particular ethnic groups. So it's a little tricky to generalize, but that's what I would have to say about that.
Thank you. How long do you schedule for a patient to have this conversation if you have an option to choose?
Well, as somebody said early on, choosing the end of the day would be my preference after the initial bringing up the issue. Initially, I would schedule a patient for a follow-up appointment at the end of the day. And then, I just know for myself, that's my last patient. There's no particular time restrictions. And it may require several appointments over time. And I would like to schedule them at the end. It means that I get home late. But, for me, I live with that because it's important. It's important to have the conversations and not feeling like you're really constrained. So end of day appointments several times, maybe over a period of time, can be one way of approaching that.
Great, thank you. If you make a mistake in how wording a statement or question and offend the patient, how do you recover?
Great question. Well, first of all, I'd want to be sure about how I offended the patient. Like, did I use a word appropriately? Or so trying to get a sense of that by saying something like, it appears that maybe I said something that you didn't agree with or rubbed you the wrong way. Can you help me understand that a little bit better? So reflecting back to the patient to clarify what's going on, number one, helps you understand it. Number two, can help reestablish a trust because you're asking them to tell you more. You want to hear more and you care what they have to say about it. And then after they've done that, you can say, I'm really sorry. I didn't mean to suggest anything that would offend you. Let me see if I can rephrase that in a way that we can talk about more comfortably.
Thank you. Okay, let's wait another few seconds to see if there are any other questions that come in. And then also wanted to make people aware that MAVEN project, we have medical experts in 68 specialties, and that also includes palliative care. Obviously, this discussion of advanced care planning is not limited to those clinicians, but I just wanted to share with you my screen to show you again when you log into the community portal, and you pull up our list of our specialties and you scroll down, you can see palliative care here. And we have two docs that focus a little bit more on palliative care. So you can get your questions answered there. And obviously, too, we have family medicine and internal medicine for questions about advanced care planning as well. So a couple more questions. Um, if you are put in a position to have this conversation but don't know the patient, how would you introduce yourself?
Um, well, first of all, you'd say, "Hi, I'm Dr. So-and-so," or "I'm physician assistant, nurse practitioner, so-and-so, and I'd like to get to know you a little bit." Um, I'm not sure if the question is being asked in the context of somebody who's specifically assigned just to have the conversation or not. But in any case, uh, I would approach it in a very general way, as we've talked about. I'd like to get to know you a little bit and understand your situation and your current condition. So, can we talk a little bit about that? And I would start with, again, the establishing empathy and trust and wanting to hear more and move slowly. Uh, but again, you're not going to be able to get to where you want to go unless the patient is comfortable, is feeling that sense of rapport and trust at their end. So that's number one. And you go from there.
Great. And Dr. Batista was saying if, for instance, if she was covering for another provider out on leave or in the hospital.
I see. Well, it depends how long you're covering for that provider. I mean, if it's just a one-time thing, then you might want to wait for the provider to come back. If it's for an extended period of time, then you'll just have to proceed as I mentioned and say, "I'm filling in for Dr. So-and-so. And by the way, I've noticed there's things that we should probably start talking about, and I'd like to hear more from you about X, Y, or Z."
Great. That's wonderful. Good. Well, I am going to give everybody a few minutes back. Again, Dr. Candell, thank you so much again for giving this very important presentation. Thanks to all for all of those excellent questions. A big thank you to Generations Family Health for requesting this session and encouraging other of our partner clinics. We have a catalog of over 200 topics. If you'd like to have a request for your clinic, we would love to do that. And thanks to all of the clinicians for the amazing work that you do every day in taking such good care of your patients. And MAVEN Project is here to support you. So everybody have a terrific day.
Thank you, everybody.
Great. Wonderful. Well, Peter, thank you so much.
Thank you.
Really
You have
appreciate that.
couple of things. Do you have any suggestions for me?
Um, well, let's see. I thought overall it was great, and you've got a really great slide deck. And I maybe say the only thing is just speaking a little bit more quickly. Like, I mean, you have a nice pace, but I think it could be you could go a little bit faster.
Okay.
I mean, and obviously you have plenty of time, so there's not you didn't need to rush in terms of the timing, but maybe the pacing just a little bit more quickly.
Yeah, that's good. What else?
Yeah, no, otherwise I thought it was really good. And I mean, you have a really nice way about you and think that, people want to know that the language, right? And how to talk to somebody and those examples of the, different phrasing because, most people don't have experience with that.
Okay, great. I'm always interested in feedback. So if there's other stuff that comes up in the survey that I should know about, I mean, aside from thank you, this was great, but if there are suggestions or recommendations, I would love to hear.
Course, yeah, definitely. We always share that with you. Kristen, usually like within a month, like we kind of leave it open, for them to complete the surveys and she'll like send you a summary. And then also on the community portal on that homepage, like where it says community news feed at the top. Actually I can share with you what that looks like. Hold on a second. I can get it queued up on my screen. I'll show you where you can find the reporting for yourself for things. Let's see here.
You can figure it out, Jill.
Okay. Well, I'm just here here. And this is the home page,
Yeah,
and up at the top, then it
yeah.
says reporting here. And then
Oh,
you can click that, once you pull up the report, mine takes a minute to load, but then you can click on the educational session tab. And I think some of the comments come in through there. And just as a reminder, they're sometimes unfiltered. So whereas Kristen usually does a good job, if there's feedback or negative feedback, we try and phrase it in a constructive way. So, but anyways, this is like you have your main volunteer dashboard, and then down here, there's different tabs. So for education sessions, you
okay,
can see the average provider satisfaction, and then there's like a section with individual survey feedback.
great. It's a great website, by the way.
Thank you. Yeah, we like it, and we're always trying to make improvements to it as well. Good. Well, take care. So good to see you, and thank you so much again.
Sure. Take care, Jill.
Take
Thanks.
care. Bye.